Welcome to StudyNeuro. In this lesson, we will explore Adamantinomatous Craniopharyngioma, focusing on how it develops, how it presents clinically, and how imaging and pathology help establish the diagnosis. We will also look at treatment and the problems that can persist after treatment. Let's begin. By the end of this lesson, you should understand where Adamantinomatous Craniopharyngioma comes from during embryonic development and where it typically arises around the sellar and suprasellar region. You should also be able to recognize its common clinical presentation and identify the important findings on computed tomography and magnetic resonance imaging. We will then examine the characteristic microscopic features that support the diagnosis, including the role of the catenin beta-1 gene and beta-catenin signaling in tumor development. This molecular pathway is central to understanding the biology of Adamantinomatous Craniopharyngioma. It is an important distinction. Finally, we will discuss the principles of surgical and multidisciplinary management, with particular attention to the difficulty of controlling the tumor while protecting near-body critical structures, and we will review important complications and long-term effects that may follow treatment. For more high-yield neuroscience education and clinical pearls, join the StudyNeuro community on YouTube, Facebook, TikTok, Instagram, and X. Follow StudyNeuro for more medical learning content.
Craniopharyngiomas are epithelial tumors that arise in the sellar and suprasellar region, close to several structures that are essential for vision, hormone regulation, and normal brain function. They usually grow slowly. However, they can invade nearby structures. Two major histological types are recognized: Adamantinomatous Craniopharyngioma and papillary craniopharyngioma. Adamantinomatous Craniopharyngioma occurs mainly in children and younger adults, although it can develop at any age. Symptoms usually result from pressure on nearby structures, particularly the optic pathways and hypothalamus, while involvement of the pituitary gland, pituitary stalk, or third ventricle can produce visual, endocrine, and neurological problems. The clinical effects can be substantial. Although Adamantinomatous Craniopharyngioma is generally considered histologically benign, its location makes it potentially serious. Patients may develop lasting visual impairment, hormone deficiencies, cognitive problems, or hypothalamic dysfunction. Benign does not always mean harmless.
Adamantinomatous Craniopharyngioma is the most common craniopharyngioma subtype in children and represents an important cause of sellar and suprasellar tumors in the pediatric population. It can also occur in adults. Age is a useful clinical clue. The tumor has a characteristic bimodal age distribution, with one major peak during childhood and another in middle adulthood. There is no strong preference for either sex. In children, the tumor often has prominent cyst formation and calcification, while hypothalamic involvement is also common. These features can influence both presentation and treatment. Age can therefore provide an important clue to the likely tumor subtype, but it cannot establish the diagnosis by itself. Definitive classification requires pathological assessment. Adamantinomatous Craniopharyngioma is traditionally thought to develop from epithelial remnants of Rathke's pouch, an embryonic structure that contributes to formation of the anterior pituitary. During normal development, these cells should regress, but some remnants may persist along the craniopharyngeal duct. These remnants can provide the cellular basis for tumor formation. At the molecular level, tumor development is strongly linked to activation of the wingless-related integration site and beta-catenin signaling pathway. This usually results from acquired mutations in the catenin beta-1 gene, which encodes the beta-catenin protein. The pathway becomes abnormally active. In simple terms, persistent embryonic epithelial remnants acquire characteristic molecular changes that activate beta-catenin signaling, driving the development of Adamantinomatous Craniopharyngioma. Adamantinomatous Craniopharyngioma typically arises in the sellar and suprasellar region, often involving the pituitary stalk and extending toward the third ventricle. Its exact position varies, but it usually develops close to important visual and endocrine structures. Location is critical. As the tumor grows, it may extend upward into the third ventricle or laterally toward the optic apparatus and cavernous sinus, while inferior extension can involve the sella, and posterior growth may reach the hypothalamus. These patterns help define the tumor's surgical relationships. Several critical structures lie next to the tumor, including the optic nerves and optic chiasm, the pituitary gland and stalk, the hypothalamus, the third ventricle, and major cerebral vessels. Because these structures control vision, endocrine function, and neurological activity, injury can produce serious, permanent deficits. The main surgical challenge is tumor adherence. When the tumor is firmly attached to the hypothalamus, optic apparatus, or major blood vessels, attempting complete removal may carry greater risk than leaving a small residual tumor behind. Safety comes first. The clinical presentation of Adamantinomatous Craniopharyngioma depends on the tumor size, location, growth rate, and involvement of the hypothalamus. Symptoms often develop gradually as the tumor affects nearby structures. The presentation can vary widely. Visual problems are common when the tumor affects the optic pathways, with patients developing progressive loss of vision or visual field defects, while advanced compression can lead to optic atrophy and permanent visual impairment. Vision may deteriorate slowly. Raised intracranial pressure can occur when the tumor obstructs cerebral spinal fluid pathways and causes hydrocephalus. Patients may develop headache, nausea, vomiting, or papilledema as pressure within the skull increases. This can become clinically urgent. Endocrine dysfunction is also common because the tumor can affect the pituitary gland and its connections. In children, impaired growth or abnormal puberty may be early signs, while hormone deficiencies can also cause hypothyroidism, adrenal insufficiency, hypogonadism, or diabetes insipidus. Hypothalamic involvement produces another important group of symptoms. Patients may develop excessive weight gain and obesity because appetite and energy regulation are disturbed, while sleep problems and changes in cognition or behavior may occur when hypothalamic function is significantly affected.
Endocrine dysfunction is common in Adamantinomatous craniopharyngioma because the tumor can affect the pituitary gland and the hypothalamic pituitary axis. This can interfere with normal hormone production and regulation. The effects may be significant. Growth hormone deficiency can impair normal growth, while central hypothyroidism results from reduced thyroid-stimulating hormone activity. Adrenocorticotropic hormone deficiency can reduce cortisol production, and gonadotropin deficiency may affect puberty and reproductive function. The tumor can also compress the pituitary stalk, causing increased prolactin levels, while damage to the pathways controlling water balance may lead to diabetes insipidus. Some patients develop deficiencies involving several pituitary hormones at the same time. In children, these hormonal disturbances may present as poor growth, delayed puberty, or abnormal weight gain, which can sometimes be the first clue to an underlying craniopharyngioma. Early recognition is important. A baseline endocrine assessment should therefore be performed before treatment and repeated during long-term follow-up, because hormone deficiencies may persist or develop after surgery or other treatment. Computed tomography is particularly useful in Adamantinomatous craniopharyngioma because it shows calcification and bone anatomy very clearly. This makes it valuable when defining the tumor and planning surgery. Calcification is important. On computed tomography, the tumor often appears as a suprasellar mass with both solid and cystic components. Calcification may occur within the tumor itself or along the cyst wall, while contrast enhancement can vary between different regions. When the tumor blocks the third ventricle, cerebrospinal fluid can accumulate and produce hydrocephalus. Computed tomography also shows the extent of calcification and nearby bony structures, helping the surgeon understand the anatomy before treatment. A calcified and cystic suprasellar mass, especially in a child, is a strong imaging clue for Adamantinomatous craniopharyngioma. It is not diagnostic by itself, but it should raise strong suspicion for this tumor.
Magnetic resonance imaging is the main imaging method for assessing Adamantinomatous craniopharyngioma. It shows the extent of the tumor and its relationship to nearby structures,
which is essential for planning treatment. Anatomy matters greatly. The tumor often contains both solid and cystic components, with signal intensity that varies between different areas and enhancement that can be uneven after contrast. Some cysts contain protein-rich or cholesterol-rich material, which can produce high signal intensity on T1-weighted images. Magnetic resonance imaging also helps determine whether the tumor extends into the hypothalamus or third ventricle, while showing its relationship to the optic apparatus, pituitary stalk, and nearby blood vessels. These details can strongly influence surgical planning. Several imaging sequences provide complementary information. T1-weighted and T2-weighted images show the tumor and its internal structure, while fluid-attenuated inversion recovery imaging can help characterize surrounding and cystic components. Post-contrast T1-weighted imaging assesses enhancement, and diffusion-weighted imaging may provide additional information when clinically appropriate.
Histopathology provides important clues to the diagnosis of Adamantinomatous Craniopharyngioma. The tumor typically contains squamous epithelium with peripheral nuclear palisading, while areas resembling stellate reticulum may also be present. These are classic findings. Cyst formation is common, and the cyst contents may contain wet keratin, which is one of the most characteristic features of this tumor. Cholesterol clefts, calcification, and chronic inflammatory changes can also occur, particularly within the cystic and degenerative areas. Wet keratin is a key diagnostic clue. Its presence strongly supports Adamantinomatous Craniopharyngioma when interpreted alongside the other histological findings. Another important feature is nuclear accumulation of beta-catenin, which reflects activation of the wingless-related integration site and beta-catenin signaling pathway. Immunohistochemical staining for beta-catenin can therefore support the diagnosis, especially when the microscopic features are less typical. The molecular biology of Adamantinomatous Craniopharyngioma is strongly linked to changes in the catenin beta-1 gene and the wingless-related integration site and beta-catenin signaling pathway. The catenin beta-1 gene produces the beta-catenin protein. This pathway is central to tumor development. When the catenin beta-1 gene is mutated, beta-catenin can accumulate inside cells and enter the nucleus, where it alters gene transcription and promotes abnormal cellular signaling. In Adamantinomatous Craniopharyngioma, this process is particularly characteristic, with clusters of tumor cells showing prominent nuclear accumulation of beta-catenin. These findings help distinguish this tumor from other craniopharyngioma types. Adamantinomatous and papillary craniophryngiomas are distinct tumor types with important clinical, histological, and molecular differences. Adamantinomatous craniopharyngioma can occur in both children and adults and commonly shows calcification, cyst formation, wet keratin, and mutations in the catenin beta-1 gene. Papillary craniopharyngioma occurs mainly in adults and is characteristically associated with the BRAF proto-oncogene valine 600-glutamic acid mutation. It usually has less prominent cyst formation, calcification is uncommon, and wet keratin is absent. Recognizing these differences helps distinguish the two tumor types and supports accurate diagnosis and treatment planning. Management of craniopharyngioma requires a multidisciplinary approach because treatment can affect vision, hormone function, neurological status, and hypothalamic function. The plan must be tailored to the individual patient. One approach does not fit everyone. Age and tumor characteristics strongly influence treatment decisions. The size and location of the tumor help determine whether surgery is technically feasible, while hypothalamic involvement can make aggressive treatment more hazardous because this region has important roles in appetite, metabolism, behavior, and endocrine regulation. Visual status and existing endocrine function also need careful assessment before treatment, since damage to the optic pathways or pituitary system may produce permanent deficits. Surgical accessibility matters as well, particularly when the tumor lies next to critical structures.
Finally, any residual tumor must be considered when deciding whether further surgery, radiotherapy, or continued surveillance is appropriate. Treatment of craniopharyngioma is guided by tumor anatomy, growth pattern, and the structures involved. Surgery is often the main treatment, with the goal of achieving the greatest tumor control that can be obtained without causing unacceptable neurological or endocrine injury. Safety comes first. When the tumor can be separated safely from critical structures, complete removal may be considered. However, if it is firmly attached to the optic pathways, hypothalamus, or major blood vessels, leaving some tumor behind may be safer, because forcing complete removal can produce serious long-term disability. Radiotherapy uses targeted radiation to control tumor cells that remain after surgery or return later. It becomes particularly useful when further surgery would carry a high risk of neurological or functional damage, and it can provide effective control without attempting another major resection. Cyst-directed treatment focuses on the fluid-filled component of selected tumors. Drainage or catheter-based procedures can reduce cyst size, while treatment delivered directly into the cyst may be considered in carefully selected patients. These approaches can sometimes reduce the need for extensive surgery. The central principle is maximal safe treatment. The objective is not complete anatomical removal at any cost, but durable tumor control while preserving neurological, visual, endocrine, and hypothalamic function. Complications can result from the tumor itself or from its treatment. Visual impairment may occur when the tumor or surgery affects the optic pathways, while hypopituitaryism develops when normal pituitary function is damaged. These problems can require long-term treatment. They matter greatly. Diabetes insipidus occurs when the body cannot regulate water properly because of reduced antidiuretic hormone function. Hypothalamic obesity can develop when hypothalamic injury disrupts appetite and energy regulation, sometimes causing severe and difficult to control weight gain. Cognitive dysfunction and behavioral changes may also occur, particularly when the hypothalamus or nearby brain structures are affected. Hydrocephalus means abnormal accumulation of cerebrospinal fluid within the brain, which can result from obstruction of normal fluid pathways. Cerebrovascular complications are less common, but may occur when major blood vessels are affected by the tumor or treatment. Finally, tumor recurrence remains an important concern and requires continued imaging surveillance after treatment. Long-term follow-up is an important part of care after treatment. Patients may need lifelong endocrine follow-up to monitor hormone function because some deficiencies can develop or persist even when the tumor remains controlled. Hormone replacement is used when necessary. This monitoring continues for years. Regular magnetic resonance imaging is also needed to watch for tumor recurrence or progression, while visual assessment helps detect changes that may affect vision. Neuropsychological evaluation can assess memory, attention, learning, and other cognitive functions, especially when the tumor or treatment has affected the hypothalamus. Weight and metabolic monitoring are also important, since hypothalamic dysfunction can lead to major changes in appetite, weight, and metabolism. Survival does not always mean functional recovery. A patient may remain alive and tumor-free, but still have significant neurological, visual, endocrine, cognitive, or hypothalamic problems. The long-term goal is therefore broader than tumor control alone. It is to control the tumor while preserving function and supporting the patient's quality of life over time. To conclude, Adamantinomatous craniopharyngioma is a tumor that mainly affects children and arises around the sellar and suprasellar region. Imaging commonly shows a mixed solid and cystic mass, with calcification being a frequent finding. Histologically, the tumor has characteristic palisading epithelium and wet keratin. It is also associated with mutations in the catenin beta-1 gene, which cause abnormal beta-catenin signaling. These findings help distinguish it from other types of craniopharyngioma. The major clinical problems occur when the tumor affects nearby visual pathways, pituitary structures, or the hypothalamus, leading to significant long-term functional problems. Preservation of function matters greatly. Management focuses on achieving the best possible tumor control while limiting damage to normal structures, and patients require long-term multidisciplinary follow-up to monitor for recurrence and delayed complications. For more high-yield neuroscience education and clinical pearls, join the StudyNeuro community on YouTube, Facebook, TikTok, Instagram, and X. Like, comment, share, and subscribe. Thanks for watching. Stay tuned for more.